report, validate the report, the CCG report, ITPC. And we are here to maybe to discuss and validate it.
Gamnass coordinates. Gamnass is the network of HIV people living with HIV, their societies. So we have started the collection of the data since June. June, July, and August data were collected. The data was analyzed, and then the report was generated. Then data for September, October, November was also collected, and that's the data we are coming to discuss today. The first 3 months, June to August, the number of people who have been provided services and compare it to what has happened for the second quarter. So today, that report is going to be shared with all of us here. It is from that report that that message was generated, which I think was shared with all of you, as to their findings. So one of the CCG members will take us into the detail of the report today. And if any of us have any comments or any concerns, this is where we would share them, we'll discuss them. And then the CCGs will do any further adjustment on that one, hopefully on Saturday.
HIV is diagnosed through laboratory tests, through a blood test. And HIV is not curable, but it is treatable with drugs referred to as antiretroviral drugs. Treatment as prevention is a term that is used to describe HIV prevention methods that use art to decrease the chance of a person passing on HIV to others. That is what we refer to as treatment as prevention. HIV treatment is used for the benefit. For the person living with HIV, and to protect negative HIV people from HIV infection. So the treatment essentially is to help the person that is infected to live positively with the virus, whilst at the same time protecting the person who is not infected from contracting the HIV virus. Number of people living with HIV that have received a viral load test, number of people living with HIV that received their viral load test results within 2 weeks of testing, of taking the test, and the number of people on earth who received viral suppression. Those are the indicators. For the 2 quarters, number that received or that did HIV test in June were 165, July 365, August 228, September 247, October 300, November 324, and December 243. Whereas amongst those people who received their test results were 153 for June, 326 for July, 212 for September, 215, sorry, for August, 215 for September, 240 for October, and 112 for November, and 217 for December. That is the graph showing the various months and the VICT uptake or VCT uptake in various months. For the month, for September, for Basse District Hospital, in July, 123 people did HIV test. In June, rather, 126, and July, 116, August, 120, September, 68, October, 468, November, 587, and December, 239. whereas those that have received their results were 123 for June, 116 for July, 120 for August, 67 for September, and 468 October, 587 for November, and 239 for December. That's for Basse District Hospital. And that's the graphic representation or presentation of that report. From Farafeni General Hospital, number who received tests for June were 888, July 229, August 254, September 258, October 111, November 248, and December 215.
Of course.
Of those that have received their results were 88 for June, 295 for July, 249 for August, 258 for September, 111 for October, 248 for November, and 215 for December. From the graph, we would see that it's perhaps only in August that few people did not receive their results that have come for the test. From SOS, those that have done HIV test were 127, July 158, August 149, September 123, October 166, November 128, and December 116. Of those that have received their results, 127 for June, 158 for July, 139 for August, 122 for September, 163 for October, and November 126, and December 116. Again, we would look at the a slight variation here in the number of people that did the test and those that have received their results in the months of July, August, October, and November. For Bansang Hospital, Bansang General Hospital, those that have received or did HIV test, 132 for June, 250 for July, 128 for August, 83 for September, 242 for October, 451 for November, and December 306. Of those that have tested or received their results, 132 for June, 250 for July, 128 for August, 83 for September, 242 for October, 450 for November, and 306 for December. There is no difference in the number that have been tested and those that have received their tests from Bansang over the period. EFSTH, those that have done a HIV test, 5 for June, 531, July 531, August 305, September 236, October 286, November 338, and December 330. Out of those that have received their results, 531 for June, July 531, August 300, September 221, October 280, and November 331, and December 328. You can see difference in the number that have 229 rather that have come for the test and received those that have received their results, especially in the months of August, September, October, and November. This is which center? We have a problem here. Which center is this? Siganov. Yeah? Siganov. Yes. Right. Here the heading has disappeared. This is for Sibanor, for don't worry, for June 2017 we have 221, July 254, August 246, September 203, October 277, November 246, and December 273. Whereas those that have received their results were 221 for June, 253 for July, August 246, September 203, October 277, November 246, and December 273. So it's only for the, yeah, it's like everybody who did the test received their results from Sibanor. Having trouble here. SL, yeah, from SL District Hospital. Those that have received or those that have done HIV test in June, 0, July 274, August 262, September 276, October 234, and November 147, and December 177. Those that have received their results in this same months, 200 for June is 0, for July 274, August 259, September 275, October 234, November 174, and December 163. So we realized that in the month of go to the graph, in August, September, and December, there has been people who were screened, but they've not collected their results for one reason or the other. Yeah. So the other indicator, like I said earlier, is number of people that have been initiated on ART. Now, this is the data that we have received from the various ART centers, ART sites, that have initially started antiretroviral treatment. For Serekunda General Hospital, in the month of June, you have 2, July 14, August 17, September 7, October 26, November 15, and December 16. For Basse District Hospital, June 9, July 10, August 6, September 78, wow, October 12, November 14, and December 7. Very funny patterns here. Farafeni Hospital, June 7, July 6, August 9, September 11, October 4, November 7, and December 14. For SOS Clinic, June 5, July 1, August 1, September 0, October 1, November 5, and December 3. For Bansang General Hospital, June 4, July 4, August 7, September 2, October 8, November 5, and December 0. EFSTH, Edward Francis Small Teaching Hospital, June 13, July 19, August 34, September 8, October 21, November 22, and December 6. Sibanor Clinic, June 14, July 20, August 8, September 6, October 5, November 11, and December 6. Buyam General Hospital, June 6, 8, July 8, August 73, September 10, October 2, November 5, and December 10. Hands-on Care, July 43, I'm sorry, June 43, July 41, August 43, September 26, October 54, November 41, and December 28. Yundum Army Barracks, June 7, July 3, August 2, September 0, October 2, November 6, and December 4. Summer District Hospital, June 13, July 1, August 2, September 15, October 19, November 38, and December 12. Whereas for SL, June is 0, July 8, August is 3, September 12, October 7, November 2, and December 3. So the national PLHIV total that have been initiated on Earth from June to December totals in the month of June 125, July 35 rather, August 205, September 175, October 161, November 171, and December 110. Those were the national figures for newly initiated on art from the various art sites over the period. So those are the graphs from the various facilities. All right. Okay. That's the graphs. Right. Now, the monthly for June, you have 5,454. For July, 6,716. August, 7,543. September, 7,474. October, 7,643. November, 5,431, and December 5,403. 404, right? So from June, you can June to December monthly, you can see some funny patterns here too. In some places, you can see in some months the figures go up, and some months they decline. We would not know the explanations to those declines anyway. All right. So PLHIV is on art at art centers by the trend analysis. Okay. We've looked at the first 3 months against the last 3-4 months. Now let's look at the trend here. In June 2006, major art sites, okay, for like Serekunda Hospital, Basse District Hospital, Bansan General Hospital, Edward Francis Small Teaching Hospital, Sibanor Clinic, Buyam General Hospital, and Hands-on Care. June for Serekunda General Hospital, or 465. Okay, and for July, they had 298 people that were on art. In August, 465. Yeah, and in September, 460. So it has dropped slightly again. And in October, 486. It has picked up again. And in November, 410. It dropped again. And that trend continued till December to slightly increased in December 426. For Basse District Hospital, in June they had 342 patients on art. For July, 352, slight increase. August 358, again the upward trend continued. In September 362, still going up. In October 321, it took a downward trend. November 324, slight increase, and in December 322, downward trend. In Bansang General Hospital, for June, they had 470 patients on that. July, 486 increased. August, 488, the same upward trend continued. In September, 427, it went down. On October, 503, well, it went up again. November, 532, still going up, and in December 524, it went down slightly. For Edward Francis Small Teaching Hospital in June, they put they had 374 people put on ad. In July, 1,666 were put. 68 were on ad, and in August 1,701 went up. In September 1,736, upward trend continued, and October 1,756, still the same continued. In November 1,163, one would wonder what happened at Edward Francis Small Teaching Hospital. And in December, 1,169. All right. In Sibanor, June 17, July 371. That was a good increase. August 822. In September 583, downward trend. October 592, slight increase, and November 589, a slight drop, and December 605. That's a good upward trend. Buyam General Hospital for June have 455, July 455, same number. August 528, slight increase. September 589, that's a good increase. In September 424, that's a drop. October 427, picked up a little bit. And November 433, picked up again. And in December 431, a slight drop. Hands-on care. In June, we had 2,554. In July, 2,595, slight increase. In August, 2,633, and still an upward trend. September 2,644 maintained. October 2,692, still the trend maintained. But in November, 1,165. Again, you would wonder what happened at hands-on care in November, and December 1,163. So those are the trend analysis from June to December 2017.
It's like he's saying, the viral load is a concern. And even in our catch-up plan, we saw it. Because what happened was, when we have the viral load machine installed, like we are saying, these electricity challenges, yes, it's one of the things. The capacity that he mentioned for that, there was a time there was only one person at the lab. It is just recently that the other one who came from studies came back. But there was a time, about 2 years or 3 years, it was only one person doing that. Doing the viral load, doing the CD force at that central level there. So like his capacity is an issue in the catch-up plan, capacity to add these strategies to address those capacities. Because each of these 390s, we looked at it during the catch-up plan, and we see what the barriers are, and we say what strategies are we going to put in place to address those barriers. But for viral load is equally a concern, like we are all saying, and we are going to address. So we have some gene experts, we need some cartridges for them to do the dual functions, and the capacity issue is going to be addressed. Since here, we have been fortunate enough when we were launching the catch-up plans, which you can dilate on, we had the regional director from Senegal. It was even taken to, they took
resources, all types of resources, financial, technical resources has been addressed in this plan. And we have also quantified and giving the figures for this, for the plan. So I think this is an important achievement for the country, and it has not stopped to that. We have also engaged with the relevant national authorities at the highest level, the political level. We have engaged with the president, and he has assured us of his government commitment and support to ensure the successful implementation of this plan. So I think this is really laudable, and we are indeed glad that we have also started the process of the advocacy, the process of resource mobilization. Awa has just said that they were busy doing some concepts yesterday to address some of the issues that have been highlighted in the catch-up plan. And we hope that also UNAIDS will embark and will also lead or be part of the process that mobilize the requisite resources to have this plan implemented. And I think this is one of the key commitments and why UNAIDS has pushed for the plan to be developed and implemented in the West and Central African region, and including the Gambia. And we also want to assure you that this is an opportunity also to look at some of the community involvement. I think the West Africa catch-up plan, which we are driving, our national catch-up plan, really puts emphasis on the need for community involvement. And this is really needs to be buttressed and by the different sectors so that all hands are on deck. We have seen that it's not enough to leave it at the facility level. We have seen that it's not enough to leave it at the level of the experts. We also need the communities to be involved. And that's the essence why the observability is important. And we want to underscore that there is need for the community involvement to address the 390s. And I think we're in the right steps. We need to get more people, get more communities, more people involved in the testing of people, bringing people to be tested, convincing people. We need to get the numbers. I think this is very important. We need to get them to be involved in treatment. And Mr. Sarr has said it, even to get the viral load tested. Throughout the spectrum, they need to be involved. To me, I think this is something, a key ingredient of the success of the catch-up plan. We cannot do it without the communities. They have to be fully involved. And for me, what I would say that for the Gambia, it's possible. For example, we have, the prevalence is low, the population size is small, the number of PLs that we're talking about is small, 21,000. To me, 22. To me, I think Gambia can be a success story in the region, in the world, to eliminate, to say that we have achieved the 3 zeros by even before 2030. So I think we're in the right track. Let's put all hands on deck. Let's ensure that by 2020, we're able to get the 390s in order for us to be able to end HIV and AIDS in the Gambia. Thank you.
The reason for this project is this project started since 2017. It has been going on since July. For this meeting that we are having today, which is called the Advocacy Forum, the reason why we are having this thing is after the data collectors have collected some data. The data that they collected will be reviewed by the CCGs. The CCG, when they review the data, they will come up with some advocacy issues. So those advocacy issues are the ones that we are discussing here at the forum here. Based on that, the stakeholders were here, UNH are here, NAS is here, NACP is here, CCM are here, and including the consultant, who have already developed this document. Based on that, we will work on those documents, and after that, we will invite the stakeholders to make sure that at least what have been raised with the CCGs, will be tackled as quick as possible. As you know, ITPC is a project that is funded by a global fund, and our PRs are in Abidjan. So from there, you have the IPTC Global, which is in Geneva. So we all work hand in glove to make sure that at least we help the PLs to get access to service, services that are actually quality service, as I said. But we are trying our level best to make sure that at least all those issues that are raised will be tackled as soon as possible, so that we go forward.
Well, thank you. The focal person has explained the background of the project. Just to add a little, the Global Fund provides funding to countries, particularly in the low and middle income countries, for efforts to reduce and then to put a halt to HIV. But the Global Fund in each country, they also have what they call the CCMs, that's the country coordination mechanisms. And then they have what they call also the local funding agents. But the CCM comprise mostly of these care providers and the other partners. It's good to know from the beneficiary too, right? The care provider will give his statement, the program manager will give his statement, but you want to know the beneficiary, their own side of the story. So this project is to get the side of the story of the beneficiary. That is the PLHIV community. That is why the data collection is done by the PLHIV community themselves. It's not by the service provider. They want to get it from the beneficiary. And the beneficiary, having collected data, it empowers them now for them to demand for improvement in the care provision. A lot of the PLHIVs, if you look at the issues related to access to service, some of them, the distance they travel to get to care, to access care. For example, in the Gambia, someone who is on a PLHIV on treatment, coming from Koina, have to look for transport to go all the way down to Basse. Or somebody in Fodekunda have to go all the way down to Basse. If it is during the rainy season and there is transportation problem, his care is affected. Someone even in Katong, who is on ART treatment, has to go all the way down to either Brikama, which is hands-on care, or to Serekunda, or to Banjul. Somebody in Kiang Karantaba, to the road is about 27 kilometers. From that side again to go to Soma or to go to Buyam, it's a distance. So this data is, why this side of this data is collected by the PHIVs themselves so that they give their concerns, right? On the care provision, how adequate it is, some of the services they want, whether they are receiving them. And then this data is what is put together, and our task is to assist them to analyze the data and present it in a form they can present, not in a form for statisticians, but in a form a common PLHIV can understand. That's why, as they were commenting, we have the bars, because they can easily see the height of the bars and they can see the difference. But the end of the purpose of this thing is to enable the PLHIVs to demand for improvement in care being provided to the PLHIV community, whether they are accessing the tests for HIV. Two, when they go to access tests, whether their human rights is being respected, right? That is why some of the other groups, we didn't get them, but that is very important. For example, do the sex workers, if a lady who is involved in sex work, if she goes to HIV to receive care or treatment, we hope they are not being stigmatized or they are not being discriminated, right? That's one of the other areas. Similarly, as we are arguing in the hall, those who are provided care, treatment, at some point you need to know whether the treatment is working or not. So if the treatment is not working, it's known by what we call the viral load test. But so far, this is one of the main areas of our argument. People are on treatment, but whether the treatment is working or not, we are not this thing. So that's why we are strongly demanding, the PHIV community is strongly demanding for that testing to be done, which is the viral load testing. Because only then you will know whether the treatment is working or not. So these are some of the basic demands. Of course, there are some issues here and there with resources. But at least within the limited resources, we want to see improvement in the quality of care being provided to the PHIV community. And if need be, we want to ask the government and partners to increase their funding to the HIV program so that the 390s, that is anybody particularly who is tested positive, should be on treatment, right? Because now more than 14,000 of the 22,000 are not on treatment. These are some of the areas we just want to highlight to government and to partners to see how to mobilize more resources for HIV. We want every person on treatment too to have viral load testing, at least every 6 months, so that we know whether the treatment is working and needs to be improved on or not. So these are just the basic, the report is presenting. Thank you.
So for the viral load, which you are saying is a problem, it is definitely a problem for us, and it's not yet. Even at ICASA, there was an advocacy done by IPTC themselves for a routine viral load testing. What was happening here, again with resources, viral load, the reagent, one of the reagents is costing 1,000 and something. I can go into yes, that is dollars for the reagent.